Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help. Dr. Kristen Dawson, thanks for joining us again on the Wild Health Podcast. We talked about a week ago, and we gave listeners some science-backed strategies to decrease stress and increase resilience during the pandemic. But today, we're going to talk to a different group. There was an article that came out in JAMA Psychiatry on March 23rd. So do you want to start off talking about who we're going to be talking to today, who may be interested in this study?
Sure. So the two main groups that I think may get something out of today's podcast are going to be, number one, healthcare workers who are in hospitals, they're in fever clinics, they're in units that are taking care of the COVID-19 patients, either now or anticipate doing so in the near future. And then the second group that I'd like to talk to are my colleagues in mental health, people who are very eager and interested in knowing how best to respond to the mental health needs of our country sort of during and post COVID-19.
So, and our focus has kind of changed a little bit, or at least shifted slightly over the last few weeks. We started out talking to our patients and to the general public on what you can do, trying to prevent this, flatten the curve. And we've really seen a big issue in frontline providers, people getting infected, the amount of stress that we're seeing in paramedics, pre-hospital providers, ER and ICU nurses and doctors. And so we've also really focused on that group because it's a really critical resource that we have to take care of. So today we're going to be talking to those people, and this article is specifically about that. So tell me about this JAMA article.
Okay, so just to maybe even take a small step backwards, I think I've been looking for some data to help guide my efforts as a psychiatrist in responding to the mental health needs of our country. So I think in general, a lot of us in mental health have been expecting to see an increase in PTSD, an increase in depression and anxiety. We're anticipating that we're going to need to be providing mental health treatment to the survivors of COVID-19, to their friends and family who may have lost a loved one to COVID-19, to our patients who have been quarantined and have had mental health impact by that. And then again, finally, the group of people that we're talking about today, which is the healthcare workers that are on the front lines treating COVID. So the article that came out this week is some data that's going to start to give us some direction, start to help us understand who might be at the highest risk for some of the psychological impacts of COVID-19. So it's an article coming out of the COVID-19 epicenter in Wuhan, China. And specifically, again, it's a study of healthcare workers. So there were kind of two questions asked in this study, led by Dr. Lei in China. The first question is, well, let's get a snapshot. Let's get an understanding of the magnitude of the mental health outcomes for our healthcare workers in the epicenter and sort of the surrounding areas of the epicenter. And number two, what are some of the factors that are going to be associated with those more severe mental health outcomes, so that potentially we can direct our efforts to those highest risk groups within a high risk population. So the study surveyed over 1,200 healthcare workers in about 34 hospitals. And again, this is a snapshot in Wuhan and the surrounding areas from a specific point in time that's in the middle of an ongoing pandemic.
And that's important for us here in the U.S. because we are the epicenter now. So it's very rare that you get a look ahead a few months of what's going to be happening. But I think the results here are probably going to be pretty translatable to New York City, to New Orleans, to the other places here in the U.S. where this is currently happening. So we can potentially get a head start on knowing what the burden is going to be and what we can do about it. So what did they find in this study?
So this snapshot was from late January to early February of 2020. They questioned healthcare workers on a couple of different screening or scales related to depression symptoms, anxiety symptoms, insomnia, and then sort of distress and PTSD symptoms. I think as expected by a lot of us, overall, the healthcare workers that were directly treating COVID-19 had a very high percentage of these types of symptoms. So 50% of these healthcare workers had symptoms of depression. 44.6% had symptoms of anxiety. 34% had symptoms of insomnia. And the big sort of culprit was distress and PTSD type symptoms affecting 71.5% of these healthcare workers.
So how do these numbers compare to the general population numbers?
So the general population numbers are going to be significantly lower pre-COVID-19 to these percentages. So again, high levels of mental health symptoms among the healthcare workers at the epicenter of the COVID-19 hospitals. How does that split between physicians and nurses? So we've got a lot of physicians we work with, a lot of nurses that I know are listening in right now. 14% of the physicians had moderate to severe depressive symptoms. So not just a couple of symptoms of depression, but we're really entering into something that was more clinically significant. And an even higher percentage of nurses at 15.5% had some moderate to severe depressive symptoms. So what are the factors, again, that might increase the severity of their symptoms or just the likelihood of them having some of these mental health outcomes? Well, number one was actually being a nurse. So that carried with it an increased risk. Being female was also a risk factor. Being on the front line versus sort of what was considered a second line responder. So somebody that's in direct contact, directly diagnosing, assessing, and treating somebody with confirmed COVID-19 was an increased risk factor. And then the people who are working really and truly in the epicenter, sort of right in Wuhan, versus even the province around Wuhan and then the greater surrounding area. So being in the epicenter was going to carry with it a higher risk of having these mental health symptoms. And then one that was a little bit interesting was having an intermediate technical title, which essentially means that within the healthcare professional system in China, if you were sort of not entry level, kind of just got out of nursing school or just became a physician and you weren't sort of the most senior staff member, the senior attending or senior nurse in charge of care, but rather those folks that fell in between, those people also had higher rates and severity of mental health symptoms.
Okay, so those are some pretty scary numbers when you think about physicians and nurses being severely depressed at 14 to 15% rate, because we're thinking about these frontline providers being taken out by getting infected, but that's a significant percentage that aren't going to be able to do their job probably to the level they did before just from that. So this is a really serious issue. That data, though, is, I guess, short term. We don't really know actually even today how those providers are doing, if they're doing better, if they're doing worse. What do we know about the longer term effect?
So again, we're right in the middle of the crisis, but there has been some studies that came out of the SARS outbreak from 2003 that can give us perhaps a little bit of insight into what the longer term mental health outcomes might be. So a study by Dr. Liu and his colleagues in 2012 surveyed some of the healthcare workers working in a Beijing hospital who had been involved in that 2003 SARS outbreak. And they went back and they surveyed these healthcare workers 3 years after that outbreak had concluded. And what they found was pretty significant in terms of depression symptoms. So 23%, almost a quarter of the healthcare workers who had worked through that time had moderate to severe depressive symptoms. And again, helpful perhaps to understand some of the factors that were associated with depression 3 years down the line. So at the time of the SARS outbreak crisis, those workers who were single at the time, those workers who were quarantined during the outbreak were at higher risk of developing depression years later. If a worker had a previous trauma pre-SARS, they also had a higher level of depression. And then interestingly, they looked at those healthcare workers' sort of actual risk of being infected with SARS. But what they found was that the individual's perceived risk related to contracting SARS, so again, not necessarily on an objective marker, how likely they were to contract SARS, but how sort of concerned and worried and convinced that they were at risk, also played a role in depression down the road. One finding that I think was hopeful was that there was a relative protective factor, or something that decreased the risk of developing depression down the road. And that was this sort of altruistic acceptance of this risk during the outbreak, meaning people who responded to a question that they wanted to help the SARS patients. And so because of that, they were willing to and rose to that risk level to conduct their jobs, helped them, helped protect them in some ways from developing depression down the road. So those are a couple of insights from a previous outbreak. Again, letting us know that the risk of depression, even years later, is still going to be there most likely.
And that factor that you mentioned, I think that makes total sense to me. We know job satisfaction in general has a lot to do with just agency and how much you feel like you're in control of your situation. So it seems like there's, and that actually correlates higher to job satisfaction than pay, than a lot of other things. It's really interesting studies on that. So I think that's a little bit at play here, but you can imagine if you're someone that's being asked to do a pretty dangerous job, if you're doing that because you're being told to, and it's quote unquote your job, and what the reward you're getting is your paycheck, I think that's very different than if you look at this situation as, okay, I am called to do this. This is the time that I get to put all of my training into practice. I'm kind of like you're the National Guard and we're going to war. Your country and people are depending on you, and you're doing this because you have the skill set and you can make a difference. I think that's a very different mindset than I'm putting myself in harm's way for a paycheck or because I'm being told to do that. And I think it's important that one of the ways that those of us who aren't healthcare providers can help those that are really kind of holding them to high esteem and thanking them for putting themselves on the line and showing that we appreciate those people. And if you are one of those healthcare providers, this is not just hyperbole, but you were kind of meant for this situation. The years of training that you put into it, now you get to finally fully utilize all those skills and all that experience and knowledge that you have. So this is a really incredible moment for all of us on the front lines. Kristen, I know you've been thinking quite a bit about how to meet the needs of all of these frontline providers who are going to be impacted psychologically by COVID-19. What initial thoughts do you have about that?
Well, I guess just to piggyback on the thought that you just expressed, I think that psychiatrists, therapists, social workers, those of us who are in mental health, are seeing what's going on around us, are deeply appreciative of the frontline workers and colleagues that we maybe have been through training with, who we know are at the epicenter and treating COVID-19 patients. And I think that part of what I've been thinking about lately. I see some of these numbers, I see the risk factors affecting our healthcare workers, and I want to sort of prepare myself to pivot in some ways the way that I have been interacting and treating patients in order to meet the needs that are going to be really significant. So, I was recently in child psychiatry and training child psychiatrists, and so I know that there pre-COVID-19 was a nationwide shortage of child psychiatrists, meaning there just weren't enough of us to meet the mental health needs of our country. So when I think about what's going to happen during and post COVID-19, I have to sort of think about ways to amplify the impact that one single psychiatrist in Kentucky can have on what's, again, going to be a really big mental health need. So here's a couple of things that I've been thinking about. Number one, I think that we have to sort of fully embrace and get on board with telemedicine. I know that a lot of my colleagues have been doing telemedicine for years and years and years. I myself had the great opportunity to train in medical school at the University of Kentucky in telemedicine, and I had a portion of my practice that I maintained in telemedicine. I think a lot of us in mental health appreciate being directly in front of patients, but again, during this time of crisis, if we're going to really reach people, we're going to have to fully switch over and embrace telemedicine. So there's a couple of things that I've been thinking about to just enhance that experience for the person on the other end. The American Psychiatric Association has a huge telepsychiatry toolkit available online. So for those of my colleagues who perhaps, aren't as comfortable, maybe didn't have a direct training experience in using telepsychiatry, there is a lot of support with this toolkit, and they've actually just added some specific recommendations for those of us working with kids and adolescents. So that's a new feature that can be of support. I've also at Wild Health engaged some technical support, again, to try and maximize the benefit and experience on the other end for our patients that are going to be receiving care via telemedicine. So number two, I'm thinking about ways that each sort of clinical hour that I devote to patient care can be amplified. And the one sort of pivot that comes to mind is moving from individual therapy and individual care to group care and group therapies. If I'm completely honest, that's not necessarily my preference. I feel much more comfortable working one-on-one with patients. But I think that in order to really make an impact and address the depression, address the anxiety, address the trauma and insomnia that we're going to see coming out of this, I have to think about what are the evidence-based interventions that are specifically tailored towards treating a group of individuals effectively and not just on a one-to-one basis. And specifically, again, in the realms of depression, anxiety, PTSD, insomnia, and stress management. And then are there some online resources and kind of extenders with apps that have some evidence of being beneficial to our patients that we can familiarize ourselves with and recommend strongly to our patients that we know are going to be helpful? So in the realm of PTSD, there are three sort of big types of therapies that have a lot of evidence for their use in our patients. Those would be prolonged exposure, eye movement, desensitization, reprocessing or EMDR, and then cognitive processing therapy. Cognitive processing therapy specifically has been applied in group settings. And so thankfully that's a therapy that I'm familiar with, and I'm simply going to go to my treatment manual and brush up on how to adjust that for a group of people who I'm working with rather than a single person.
What's the difference in cognitive processing therapy and cognitive behavioral therapy? I think a lot of us are familiar with CBT. What is the difference here?
Right. So I would say that cognitive behavior therapy You can kind of look at it as an overarching therapeutic strategy that oftentimes is tailored for specific diagnoses. So lots of evidence in anxiety, lots of evidence in depression. And then in trauma, I would say that these 3 trauma-focused therapies have their roots in CBT, but they are very much focused on the trauma and reducing symptoms of PTSD.
Are there any great online programs specifically that you would recommend for mindfulness-based stress reduction?
Yeah, so the University of Massachusetts Memorial Hospital has a online course for MBSR, mindfulness-based stress reduction, as well as mindfulness-based cognitive therapy. So they're actually up and running courses that begin at the end of April. So any healthcare workers who potentially have the time to invest in that now, it may not be that likely, but potentially in the future, can take advantage of these online courses. They are evidence-based. Again, they're online, so they're already set up to help reach a lot of folks. So for depression, I'm thinking about, again, switching from cognitive behavior therapy on a one-to-one basis into a group setting. I think it's very sort of widely used and has a lot of evidence to support its use in a group setting. Again, online, there's that mindfulness-based cognitive therapy course. What I really love about that is that there's evidence that not only it helps with depression in the here and now, so treating any depression that you're experiencing right now, but it also has been shown to reduce the likelihood of a future depressive episode. So again, looking at some of this data, knowing that years down the road, some of our healthcare workers are at higher risk for depression, this may be something that, again, helps you now, but also protects you in the future. For anxiety, again, switching from individual CBT or cognitive behavior therapy to a group CBT format makes a lot of sense. For kids, I should mention that mindfulness-based cognitive therapy has been used in kids and in adolescents, and it can be delivered in a group format. So again, things to think about if you are wanting to reach a lot of anxious kiddos right now. And finally, for insomnia, there's, again, high rates of insomnia in our healthcare workers. One resource that I think is very, very promising and hopefully will have a lot of people taking advantage of is an app for cognitive behavior therapy for insomnia. So that's CBT with a little I, CBTI. So this has been studied for quite some time. I think that it's a great tool. It can be used in conjunction with a therapist or a group therapy sort of focused on CBTI.
Yeah, and I think the insomnia can be for multiple reasons. A lot of people are very anxious during this time. They're seeing a lot of bad things in the hospital. Or you also, I mean, the problem that I had for the first couple of weeks of this is just there's so much work to be done to make a difference. I just had a hard time getting my cortisol down at night. I was waking up, not going to sleep until midnight, waking up at 4 o'clock, just my mind turning on about all the things that needed to be done. And I didn't really feel anxious. It's just so much to be done. And so for me, this is not the focus of today's podcast, but the things that helped me the most there were started taking phosphatidylserine, which tended to help. And this is, I'm talking to healthcare workers specifically to kind of lower cortisol. And then melatonin and CBD. Melatonin is interesting. We did a podcast about vitamin A and melatonin and its potential effects, which, I mean, who knows if it's potentially protective at all or has an effect, antiviral, but there was some mild evidence for that, and it's really a very low risk supplement. So that little kind of cocktail really helped me with my sleep. But CBTI obviously is one that is not going to have really any side effects, so great option. Any other thoughts specifically for those in mental health right now?
Yeah. So I think, again, you're expressing your experience of feeling the effects of this stress. I would say that for mental health providers, we're not immune to it either. We work in mental health. We have a lot of knowledge, I think, about how to help our patients, but sometimes we, need to be gently nudged to first take care of ourselves. So I think, that would be first and foremost is we're going to see increased demand. There are going to be ways that you may have to adjust your practice. You may have to learn some new skills. You may have to be, delivering care in a way that wasn't necessarily your first, second, or third choice, meaning, now I'm doing telemedicine all the time, or, now I'm doing therapy in large groups, and I didn't necessarily like that option. So again, sort of engage that sense of purpose, that sense of altruism that we were talking about earlier. So, we train for this. We want to be on the front lines of delivering really excellent mental health care. And then practice your active coping skills. So just as you're going to, be encouraging your patients to use active coping strategies, healthy coping strategies, you want to make sure to double down on that for yourself. The other thought I had, I'm not necessarily in a position to be screening mental health symptoms in a hospital system at this time, but I think if you are a mental health worker and you're working in one of the hospitals or clinics in the epicenter, taking this data that we talked about today and recognizing that there is going to be a very large mental health burden, and we want to understand and capture those healthcare workers that are experiencing that so that we can direct the care to them. So consider perhaps administering some of the screening questionnaires that we talked about that are going to capture symptoms of trauma, anxiety, depression, and insomnia.
And any last words of advice for the healthcare workers on the front lines?
Yeah, I think, again, have to start off with just gratitude towards you and saying thank you so much. Your colleagues in mental health are very appreciative of everything you're doing. Clearly, I feel strongly about sort of meeting your needs and understanding what the mental health outcome might be for you. And just want you to know that I'm thinking of you and we're making preparations to deliver the mental health care that you need and that you deserve. The next thing I would just say is if you're able to kind of find a moment or two to revisit that sense of purpose, that sense of altruism that led you to become a helping professional, that led you into your career in healthcare, I think that might be somewhat protective of some of the mental health outcomes that we're seeing in other areas. Please don't forget to utilize those active coping skills. It may be that you have a minute in the restroom between patients and you just simply take a couple of deep breaths. Maybe you have time for a meditation app that has a 60-minute guided meditation. Whatever it is, even if it's small, I would encourage you to try your best to utilize some of those skills. And then I think know that there could be some depression, some anxiety, some insomnia, some trauma symptoms that you experience both now and in the future. So if you are experiencing those, please speak up. Please let a friend, a colleague, a family member know so that they can support you as you pursue some treatment for those symptoms.
Well, thank you for all that information. I'm turned away from you right now because you were getting choked up a little bit on that last part, and I don't want to look at you. But as you were talking about it, I was just thinking about how our household is kind of a microcosm for this. I'm on the front lines doing a lot more emergency medicine shifts than I normally would. Instead of 1 to 2 a month, I may have to do up to 20 next month. Who knows how much? But I have a very supportive person at home, kind of taking care of me and making that easier, making it possible to do that work. But not everyone has that. So at Wild Health, we've announced before that if you are a frontline provider for the foreseeable future, we are happy to take care of you for free via telemedicine. So you can sign up at wildhealth.com. We don't know exactly how we're going to take care of a lot of people, but we're working on that, whether it's through group sessions or recruiting more healthcare or mental health workers. We're working on that right now, but we're there for you and we have your back, just like Kristen has my back right now. If you have other questions for Dr. Dawson, the smarter Dr. Dawson. We have our Wild Health Virtual Summit coming up in just a couple days, and you can ask your questions live there. Register for that conference at wildhealth.com. Thank you for listening, and we'll be back tonight with another daily update.
Thanks so much for listening to this COVID-19 update. Please send us your questions or follow along on Instagram and Facebook at WildHealthMD. And just to be clear, this is not medical advice. No patient-physician relationship has been established, and this resource is really for general informational purposes only. And finally, if you want to spread the word, please send this podcast to friends and family and give us a review on iTunes. Thanks again, and stay safe.